Good evening. I want to welcome you to tonight's program, the Many Faces of Lymphoma, Leukemia, and Myeloma. My name is Margaret Stauffer, and I'm going to be the moderator this evening. Just to clear up a few housekeeping items, you'll notice in your program that there are two cards that are color-coded. So if you have questions during Dr. Karamlou's presentation, you use the yellow sheet. And if you have questions during Dr. Robles' presentation, you fill out the orange sheet, and folks will come and pick those up from you at the end of their presentations. And most likely we'll be holding the questions until the Q&A period. Please help yourself to refreshments at the back. There's also a resource table at the back. We're pleased that the Leukemia Lymphoma Society is here tonight, and they've brought a lot of materials. I'd like to point out for those of you who are not familiar, the Leukemia Lymphoma Society sponsors a support group that meets monthly at John Muir Medical Center on the first Thursday of the month at 7 p.m. So there is information about that support group. They also have some services that are available to people dealing with blood cancer, so check out their materials and see if there's anything that could be useful to you as you're dealing with a blood cancer. How many of you are familiar with Cancer Support Community? I see a few familiar faces and some hands up. Even though we don't have a support group that is specific to blood cancers, we want you to know that there are many services available to you at Cancer Support Community at no cost. We have a variety of support groups, including weekly support groups for people with any type of cancer, and there are a number of people in those groups who do have lymphoma or myeloma or leukemia. We also have a number of healthy lifestyle classes, things like Qigong, mindfulness, Tai Chi, yoga, all things designed to help you support your body and your immune system as much as possible while you're going through treatment. And in addition to that, we have a number of educational workshops on various topics, from complementary therapies to advances in treatment, to creative expressive programs. So we encourage you to pick up a calendar at the back of the room and acquaint yourself with the services that are available. We are so pleased to be able to present this program tonight. Thanks in particular to Diablo Valley Oncology for making all of the arrangements and getting things going so beautifully. Our first speaker is Dr. Kasra Karamlou, who is a medical oncologist hematologist at DVO, and he's going to talk about CLL and multiple myeloma.
Thank you. Thank you very much. And I wanted to thank all of you guys for taking time out of your evening being here. Dr. Robles and I, obviously, most of these topics sometimes can take days to give you updates on everything that's going on. We'll try to sort of simplify it, try to give it a sort of a quick talk, and then leave enough room for questions and answers. But really, a lot of what we're going to be talking about is not possible without the scientists and the physicians who are dedicated to this field, and also you and your support that really allowed a lot of this science to advance. So I really want you guys to give yourself an applause for really sort of making this happen. So thanks for being here and giving us the opportunity to present the data. What I'd like to do is actually go ahead and talk about some of the updates on CLL, and then talk about myeloma as well. But one of the things that there's going to be sort of a lot of data, but what I'd really like to do in CLL especially is sort of make a story of sort of where things started and sort of where we're going or where we're headed in the future for management of CLL. So CLL is the most common leukemia in the Western Hemisphere, but we've clearly understood a lot about its biology, about its pathophysiology, and that really has allowed us to better differentiate between what patient's going to do well, what patient requires a different type of therapy, and we've really understood sort of the mechanism of the disease, and that really has allowed us to have better, more effective therapies available for CLL. if you sort of wind the clock back, back in the early 2000s, really what we really had for CLL was just various types of chemotherapy, and there was trial after trial looking at various chemotherapy regimens. And it wasn't until really 2005 where the MD Anderson group basically added rituximab, which you guys probably some are very familiar with, which is an antibody that works against most lymphomas very well, to the backbone of chemotherapy. And what they showed was a tremendous amount of response. And they saw basically responses lasting years in CLL where otherwise they were not possible. So really that sort of started a new era of therapy for patients with CLL. And with that, really, the largest trial in CLL sort of was a proof of principle trial that really looked at the backbone of old chemotherapy versus the chemotherapy plus antibody, which had worked very well in different types of lymphomas. And this German study, which was the largest CLL trial done at the time, really basically randomized patients to the old chemotherapy versus what was considered new chemotherapy. The caveat here, though, is that this particular chemotherapy really was only meant for folks who were fit and could tolerate it, because there was a fair amount of toxicities as it was used over the years. So it was really for a select group of folks who could tolerate the chemotherapy, didn't have a lot of other medical problems. And essentially what the trial demonstrated was a significant control of the disease, with a median of control of almost 5 years in patients, which at the time was unheard of in CLL. And also for the first time, we saw an improvement in overall survival in patients treated with CLL. There had been multiple other trials which combined different types of chemotherapy and never really showed that difference in survival. And this was the first trial that demonstrated a significant overall improvement in survival in patients with CLL. But in that background, there was concerns about the toxicity of that combination. So the fludarabine, Cytoxan, rituximab combination, which was known as the FCR combination, was really meant to only be used for a limited group of folks because of this toxicity. And most folks who weren't able to complete the whole 6 cycles of therapy, or they had some kind of side effects. So other alternative chemotherapies sort of came to bear, and an old drug sort of resurfaced called bendamustine, and that was felt to be a lot more tolerable, and people did much better with it. So obviously the next step was, hey, we have a combination that's really sort of limited in its use in terms of who can benefit from it. Can we substitute that with a combination that patients can tolerate better and can be just as effective? So there was a large trial which was actually presented at the American Society of Hematology meeting a year before this, that basically compared these two regimens together. And as you can see, if you look at this top sort of bar there, the responses overall were slightly better for the older regimen, and what was called minimal residual disease, which is a sort of a measurement of the molecular sort of density of the disease, was better with the older chemotherapy than with the newer chemotherapy. But what was different, and also the survival overall was slightly better for the older chemotherapy, which was the more toxic one that MD Anderson had come together, as compared to the bendamustine regimen. But what was different was the toxicities. So as we saw, it was really sort of the toxicities of the old regime which made it much more difficult to tolerate. And basically sort of the principle was that if you feel someone can't tolerate the older regimen, they can possibly benefit from the newer regimen. Maybe slightly less so, but overall the toxicity is not a problem. Certainly it's another option for patients. But within that realm also we were looking for newer drugs, because what was also happening is our treatments were sort of selective. As you know, the median age for CLL is in the early 70s, and people have medical problems. There are other things that go along with the disease itself. Therefore, it gets very difficult to be able to give the FCR type chemotherapy to patients. So basically, newer therapies were being sought after, therapies that had less toxicities and possibly more effective. One of those was actually looking at antibody-based therapies against these malignant cells. And an antibody that's been developed, which is called GA101 or Gazyva or obinutuzumab, basically was sort of a cousin of rituximab, but it felt to be sort of more effective than Rituxan was. So we had to prove that principle again. So we have a drug, potentially could be better than Rituxan, but we have to prove that it's better. So there was a large trial that again looked at the new antibody, which is called the obinutuzumab or Gazyva, and added that to an old chemotherapy drug and compared that to Rituxan plus the old chemotherapy drug, and wanted to see, have we actually moved the field forward by a new antibody? And the answer to that question was yes. The new antibody worked better, it's more effective, and this trial was specifically designed for folks who were not candidates to receive the FCR-type chemotherapy because of its toxicities. So it was a much better alternative, and it worked better than the old antibody that we're all very familiar using. So this really proved that principle as well in terms of a better antibody. There were other antibodies as well, which again sort of followed the same principle. The benefit here again, all these antibodies are designed against a molecule called CD20, which is present in most B cells. And essentially, what these antibodies do, they attack to a different component of that receptor, and by attaching to a different component of the receptor, they have different activity. And again, what we saw with the new antibody, which is ofatumumab, essentially another trial, very similar design to the older trial, adding ofatumumab to the backbone of old chemotherapy, and we saw activity very similar to the obinutuzumab in terms of its overall effect in putting the CLL in remission. So again, we're sort of made a small advance by adjusting where the antibody binds to the CD20 receptor, and based on our understanding of how CD20 worked, we were able to develop newer antibodies which actually work slightly better than the older antibodies. So again, pushing the bar forward in terms of having better treatments with longer lasting responses. But what happened overall is unfortunately at some point folks with CLL will relapse. So we haven't really unfortunately achieved or gotten to the point where we can cure CLL. Although our responses are better, patients can go into remission for a longer period of time, newer antibodies allow us to treat the disease better. There are folks who still relapse, and what the difficulty of that situation is that when you relapse, then giving additional type of chemotherapy or additional antibodies don't seem to work as well. So we had to look for something new. And what really sort of helped was understanding how CLL cells survived within the bone marrow. And that's where the story of the B cell signaling or the B cell receptor, or what's really vital for the survival of these cells, really became a huge therapeutic target for treating CLL. So essentially what happens in the normal CLL cell is that by use of the B cell receptor, so these are receptors that sit right on top of the cells, and these are always active in the CLL cells, and it gives the CLL cells an advantage to survive. In addition, it also allows the CLL cells to talk to its neighbors, and by talking to its neighbors, it gains an advantage, so it sort of grows in a friendly environment. So by activating that, it sticks in a friendly environment, doesn't leave the friendly environment, and has a growth advantage. So what was thought is that once you decipher this signaling pathway, sort of look at potential targets, there were a number of targets that were identified, as you can see on this, and obviously it's a lot more complex than this slide shows, but essentially, as you can see, here's the outside of the cell, here's the inside of the cell. You get constant signals that goes down this pathway and allows those cells to survive. So the thought was, hey, let's find particular targets, block those targets, and see what happens to the CLL. So there were a number of different trials looking at different pathways. The two that is most commonly or available currently is the ibrutinib or Imbruvica, which blocks the bruton tyrosine kinase, which is a sort of a downstream signaling pathway in the cell receptor, and then idelalisib, which also blocks the PI3 kinase delta in that same pathway. So by blocking sort of a signaling cascade in that pathway, the principle was if you do that, do you have an impact on treatment of CLL, and could you potentially have less toxicity by doing it, because essentially what you're doing is you're taking advantage of a mechanism that the cells are using to survive, and you're taking that away from them, and could that potentially theoretically work for patients with CLL? And it does, absolutely does. So these are this is an example of a patient who has had refractory disease, has seen multiple lines of chemotherapy, and obviously presented with big lymph nodes. And after a month of therapy with the drug ibrutinib, the lymph nodes are completely gone. So this really, the early trials that were using this drug really sort of proved the principle that going and stopping that mechanism really does work in treating CLL. But it does have a sort of a unique way of working, in a sense that what it does essentially by inhibiting that pathway that I showed you, what it does is those cells are no longer able to stay within their nice, friendly environment. Now those cells are released from that environment, and not only your immune system is now able to sort of kill them off, but since they're no longer within that confines of a friendly house, the cells are basically released out into the blood, and over time those cells don't have that growth advantage anymore, and they'll die. Essentially what happens is you open the garage and then you close the garage and they can't get back in, and they'll eventually sort of get lost or die. That's one of the principles of how these potentially work. And you can see that actually when you treat patients with this drug, in which that originally you see that their blood count numbers go up, and at the same time the lymph nodes shrink down, and then over time, sometimes it can take up to a year, that the blood counts eventually come down, sort of proving that principle that those cells are no longer in friendly environments, they're out and they're dying. So a very, very sort of unique, interesting mechanism of action for this drug. And if you look at the responses for this drug, they're very, very high. You're getting responses in the 80 to 90% with this drug to patients. Now, some of these patients hadn't gotten therapy before, but some had 3, 4, 5 lines of therapy before getting this drug, and they were still responding to it very, very well. And if you look at sort of the rate of the disease sort of coming back, some of these trials are still obviously very, very early, but normally what you look at is at that 50% mark, sort of how many patients have progressed or their leukemia has worsened if you look at that 50% mark. And if you look at the patients who've been treated with these drugs, either patients who've never been treated with anything else or patients who've had a number of various type of therapies, you're seeing that their responses are very, very long, and we haven't yet reached that median, which is that 50% of the patients have had their leukemia come back. So you get very striking, long-lasting responses in patients who are on the drug itself. I'll skip that one. What about sort of toxicities? Now we know that the chemotherapies, for example, the original chemotherapy that I showed you, the fludarabine, Cytoxan, Rituxan regimen, has a fair amount of toxicities, especially if you look at the cohort of patients who were in that trial who were over the age of 70. They really couldn't tolerate the treatment very well, so the treatment had to be cut short because of the toxicities that particular therapy had. But the toxicities associated with these drugs are exceptionally very, very tolerable. So you do see slightly high rates of diarrhea, although the diarrhea is very, very manageable. So blue and orange actually are toxicities that are very, very manageable. And if you look up and down this, what you're seeing is a lot of blue and orange, which are toxicities that you can manage, you can treat through, and patients can live with. And so they're very, very manageable toxicities with this drug. But again, there had to be a proof of principle. A lot of the times we get excited about drugs when you treat 30 or 40 people on them and you see great responses. We all get excited, we think it's the next coming, and there's been times where you take that concept and apply it to a larger cohort of patients, then the drug doesn't work as well. And you have to do the same thing with most drugs, because you have to prove the principle that it is better than what you're currently using. And this large trial, which is called the Resonate trial, essentially did that. So it took folks who had previous therapies and randomized them to ibrutinib, which is the drug that we talked about, and to an antibody, which is ofatumumab. And the reason that they did that is because that's the only drug that has an indication for therapy in folks who've had their CLL come back. So they had to actually compare it to a drug that's already approved and on the market for management of CLL. And essentially what we saw is dramatic differences with the new drug, or the ibrutinib, as compared to the old drug. Not only an improvement in how long the remission lasted, but also a significant improvement in overall survival. So definitely a breakthrough for patients who have had previous therapy and therapy has failed and now require additional therapy. Another compound is idelalisib, and again, this actually blocks a different pathway within that same whole receptor. And again, what you're seeing in folks who've had a number of therapies, that the drug works very, very well. And again, you see the same pattern of the lymph nodes or the white cell counts going up at first, lymph nodes shrinking rather quickly. Very, very sort of similar concept as the other drug. In terms of toxicity, it has slightly different toxicity than ibrutinib does. In terms of there's more diarrhea, there's more lung toxicity associated with this, so you have to keep an eye on that. But again, for the most part, they're toxicities that are very well tolerated. And these are all in your handouts, I think, if you want to sort of look at them in more detail. They're there for you guys to review. And this was the study that actually led to the approval of the drug and essentially compared the drug to, again, a therapy that was considered to be an option for folks who've had previous chemotherapy. And again, what you're seeing is a significant benefit to the new drug, which blocks that pathway as compared to the old drug. So definitely a breakthrough in terms of treatment for patients. And I think that's very, very important in the sense that really we've stepped out away from all chemotherapy and comparing one chemotherapy to another type of chemotherapy. And now by understanding exactly how that cell survives, how that cell has an advantage, you can block those pathways and see remarkable responses with much more manageable side effects and toxicity. So just in a nutshell, to sort of summarize what we talked about, so for someone with CLL who we consider is actually fit and can tolerate strong chemotherapy and they require therapy, the fludarabine, Cytoxan, Rituxan is still considered the standard of care. So if you can tolerate it, that's what we would like to treat you with because that has the best results in terms of overall survival. If there are concerns in regards to toxicity and you feel that somebody cannot tolerate that particular combination but they can still tolerate chemotherapy, bendamustine and rituximab would be an option. If you feel someone cannot tolerate chemotherapy at all, then you have the newer antibodies that you can combine with the older drugs. And again, you can get pretty long-lasting remission with good tolerability with those combinations. And as we saw, the new drugs, ibrutinib and idelalisib, they're both approved now for use in CLL. And they basically are gaining weight into sort of upfront therapy of CLL. And those trials currently are ongoing. And it probably, at some point over the next few years, they're going to be sort of moved up into the therapy of earlier CLL rather than waiting for folks to relapse. So that story is yet to be written. Other drugs also are very close. Obviously not enough time to talk about all the drugs that have been presented or people are working on, but ABT-199 is very, very close to, again, also being approved for CLL. There's remarkable activity in CLL. There's some concerns in regards to its toxicity, but still works quite well. So that's another option that likely is going to be approved over the next year. And then additional sort of smart bombs are under development for CLL. So the story is yet to be written in terms of other targeted therapies. So I'm going to shift gears completely now, go from CLL to myeloma. And I think we're going to ask questions at the end. But essentially, in myeloma, what I want to do is sort of go over what was presented at the annual meeting in December, just briefly talk about some of the major presentations. And one of the sort of the bigger or the larger trials that was done in multiple myeloma was what was called the FIRST trial. And this is important in a sense because it really sort of sheds light onto a combination that I think most of us are very familiar with and have used for a long time, and also proves the concept of therapy in myeloma to some extent, although there's still a lot of questions that need to be answered. But essentially, in this particular trial, they took folks who were not eligible for a transplant. So we're not talking about somebody that you're going to take into an autologous stem cell transplant. So these are folks who you're not going to transplant. And what they did is they randomized them to Revlimid plus steroids. And the steroids were given once weekly. And depending on age, the dose was different. And they basically compare that to what was called melphalan, prednisone, and thalidomide. Now, this was mostly a European study, and that combination, which is really not used in the United States a lot, and used in Europe as a standard of care, was the comparator arm. And then the next important question was continuous therapy, meaning that you get on drug and you stay on drug for as long as it works, versus treating for a defined period of time. So basically you treat and then you stop after 18 months and you come off drug. So one of the principles was that is continuous therapy better than therapy for a predefined period of time? And is this new combination better than what was considered the standard of care in Europe? And they basically also broke this down based on age, and they looked at sort of how folks did based on their age groups. But essentially the bottom line was that the continuous group, which is the blue group, did better regardless of age. So in terms of keeping the myeloma away, it was the best out of all the groups. It was better than the standard of care, which is green, and it was better than a set defined period of therapy. So in a way, it sort of proved the principle that in order to keep the disease away, it's better off if you stay on the drug continuously rather than treat yourself for a defined period of time. The challenge, however, though, and the same thing as you look based on age, the same thing happens. The challenge for this particular trial is that the survival. And the survival, obviously, with the old combination versus the new combination was different. But as of yet, there is no survival difference between the group that continues the drug versus a group that stopped for a defined period of time. And that may just be a factor of time, that maybe in another 2 or 3 years you may see a difference. But as of yet, we haven't seen the difference. And that potentially could be due to the fact that the group that only got it for a defined period of time, when they had their numbers go up, they went back on therapy, and at the end of the day, they did just as fine. But they went with a period of time where they weren't on therapy, and they didn't have to deal with the side effects of the therapy. So that's the big question that needs to really be answered. In terms of keeping the disease away, yes, the continuous therapy works better. In terms of survival, that's yet to be defined. So obviously, we like all our patients to live as long as possible, and that's really our primary goal for the most part for therapy. In terms of side effects and toxicities, I think that in this particular trial, one thing to point out is that in this particular trial, they continued steroids, for a period of time. There's been studies done in the past where the steroid you drop the steroids and you only continue the Revlimid, where for this particular study they continued the steroids on and on. Now what you see is the high rates of cataracts in the group that continued with the steroids. And I think a lot of us, when we continue, probably drop the steroids because we're sort of concerned about the long-term toxicities of the steroids. And after a while, we're not quite sure how much steroids really adds at that point. So again, to summarize this trial, really showed that the disease control is better with continuous therapy. So that's the principle that was proved by this trial. But we still don't know if survival is different. And we're waiting for more updates on this trial to see if there's going to be a difference in survival. And in terms of age, old, young, 75 years old or younger seem to benefit the same in terms of the benefit that it gives in terms of disease control. What about relapsed myeloma? So we still, obviously, we've done very well for myeloma. Patients living much longer with myeloma with multiple therapies that are available for myeloma. And we're very excited about that. But unfortunately, there are folks who still relapse from myeloma, and we need to improve our therapies for relapsed myeloma. And one of the bigger questions when folks relapse from their myeloma is do you treat them with one drug at a time, or is it better to combine a bunch of drugs together and get a better, longer duration of remission? So that's a question that we always ask, and it's been asked in breast cancer, it's been asked in multiple cancers, and the same thing is true about myeloma. Does one drug better than adding more active drugs when folks have their disease come back? And this large trial, which is called the ASPIRE trial, tried to answer that question. So folks who had their myeloma come back were randomized to either Revlimid or steroids which has an indication and is proven in that setting. And they added carfilzomib, which is another very active drug in myeloma. It's in a group of drugs called the proteasome inhibitors. And it's a newer generation of the proteasome inhibitors. And what they did is they added that to the Revlimid and the steroids, and they wanted to see if that did better than the combination of just Revlimid alone. And lo and behold, it did. The progression-free survival was significantly better, and the progression-free survival means that the disease is under control and it's not progressing. That did significantly better when you threw all the drug combinations together as compared to just using the Revlimid and the steroids together. And the 26 months that you see here, this is a group of folks who've had a number of prior therapies. That's a pretty remarkable number in terms of how long you were able to keep that disease in control, even in the setting when the disease has come back after multiple lines of therapy. And if you look at the overall responses, the responses in the blue were better for the combination as compared to the double Revlimid and dexamethasone or steroids alone. So the responses were better, the duration of responses were improved, and the toxicities for the most part were very, very manageable. And if you were able to get a very deep response, then that response obviously lasted longer. So our goal really in myeloma has changed. You know, back in the day we were happy with getting any kind of a response. Now we really are looking for deep responses because we know, regardless of age, deep responses mean that your disease is going to be controlled for a longer period of time. And we saw that by that combination, you're getting more folks with a deeper response. And because of that, more folks with a deeper response are going to have that response last longer. So that's sort of, again, another proof of principle in that setting. So really, this was a proof of principle study, again, that was just presented a few months back that did demonstrate that if you combine your most active drugs, even in the setting where the disease has come back, you're going to get a deeper response, and that response is going to last longer. So again, sort of another move ahead in the field for myeloma. But I think an exciting, and unfortunately we don't have enough time to go over all the exciting drugs that are coming around in myeloma. And I don't want you guys to worry about sort of the busyness of this slide, but one of the most exciting therapies in myeloma are these, the development of immunotherapy, sort of immune-based therapy and antibodies in myeloma. We use those antibodies a lot in CLL, we use them a lot in other types of leukemias, as well as lymphomas, but essentially they're now starting to be used in multiple myeloma. And CD38 is a receptor that's present in all plasma cells, and essentially there are two compounds, and actually there's three compounds now available that are essentially antibodies against the CD38. And all of them have had remarkable responses. Now again, there are a small number of folks that have been treated on these antibodies, but based on the early results, the results look amazingly good without really a whole lot of toxicity and side effect with the addition of these drugs. One of them is called SAR 650984, and again, this was combined with Revlimid and dexamethasone in patients who've had previous therapy and were resistant to this previous therapy. And again, you're seeing high, relatively durable responses. Again, these are a very, very small number of patients, but yet very, very exciting results. And as far as what you're seeing, the progression-free survival, it's actually quite robust for the overall group of patients with the addition of that antibody. And what is striking in this presentation was looking at the number of prior therapies that folks had. So if you haven't had a whole lot of therapies, it actually worked very, very well. So if you had only one or two prior therapies, the antibodies plus Revlimid and dexamethasone worked exceptionally well, and patients went into very, very long remissions. But if you have had more than 5 lines of therapy, then obviously it still worked, but it didn't work as well. That's why these drugs now are moving into frontline therapy, and those trials are currently underway. And some of them have had some early results which look very, very well in terms of the responses that you see. In terms of side effects, fatigue, anemia, things that you see with Revlimid and dexamethasone, really what you see are those that we don't see any sort of new toxicity except the fact that you do occasionally see an infusion reaction, like you would, for example, if you guys have had experience with Rituxan, where some folks can get a reaction to it. The same thing can happen with these antibodies, but they're not, it happens in about a third of patients who end up getting those type of reactions. But when they get it the subsequent time, it doesn't seem to be that problematic. So another similar antibody is called daratumumab. And the exciting thing about this particular antibody is very similar to the old one in terms of it's against the CD38. But what you're seeing is very, very, very high responses to this drug. So in one phase of the study, almost every patient on the study responded to the antibody. And on the second phase of the study, almost 90% of the patients who've had previously treated myeloma responded to the combination of the antibody and the Revlimid and the dexamethasone. Obviously, the dosing and all that stuff is under works, and we don't need to get into the details of the dosing and what dose was selected to move forward with. But these are two very, very exciting antibodies that, as you can see, sorry, I'm just going through these for the sake of time, that both of them, in combination with Revlimid and dexamethasone, have shown remarkable activity in patients with myeloma who have had failed previous therapy with very, very manageable side effects. So very, very exciting in terms of antibodies. Another antibody that's worth mentioning before we end is called elotuzumab. And this is an antibody that actually works against an antigen or a receptor that's present in all of the myeloma cells, which was formerly called the CS1, but now it's called SLAM F7. They've changed its name from CS1 to SLAM F7. And essentially, this particular trial took patients who've never had Revlimid and dexamethasone, but have had previous therapy, and added this elotuzumab antibody to the combination. And again, what we saw is remarkable responses, 92% at the 10 milligram dose, very, very high responses. Again, 11%, almost 58%, very, very deep responses with the combination. And the duration of these responses also are very, very long for folks who have failed prior therapy, including transplant and so forth. And the nice thing about this antibody is that you're really not seeing a whole lot of new toxicity as well with it. You do see some infusion reactions associated with it, very, very mild. But as a whole, it's very, very well tolerated and really doesn't make the toxicities of Revlimid any worse. So I'll be happy to answer any questions now.
If we could hold the questions.
Sure.
We'll give you a chance to catch your breath. Thank
Sure.
you for all of that information. What we'll do now is we'll have folks pass your questions on the yellow cards.
I will
then
throw a pitch for the clinical trials that we have.
Okay, great. Do that.
So that's up there
While people are passing those in, then we'll get started with Dr. Robles, and then they'll take turns answering questions at the end. Dr. Robles.
Thank you again for spending your time, a little bit of your evening with us. And I get the task of covering a couple different things that looks like, oh my gosh, but actually, you know, for better or for worse, it's not as bad as it looks. So the topics I'll be covering are sort of the other leukemias, and then the Hodgkin's lymphomas and the non-Hodgkin's lymphomas. So AML, that's the most common acute leukemia in the U.S., an older population on average. And it's actually one of the few malignancies where age actually is really important. There is age discrimination in AML. For most other malignancies, age, you look at it, but it's not necessarily a deciding factor in, well, what do we do? And as you've sort of heard, and one of the themes is that we have these names, these categories, but what we're realizing is that within each category, there are a lot of different diseases that just happen to be grouped together. So this is a picture of the enemy. This is AML. And when we get called to the emergency room because someone's white blood count's high and the lab technician is worried, this is what we don't like to see. And these are leukemia blasts, these purple things. And they look relatively the same, which is what you don't see on a normal blood smear. A little bit of a close-up. This is the leukemia cells in close-up. Sort of this, nice, well, not nice, but this, purplish nucleus here. You can see these little dots in there. Those are called nucleoli. That's what we don't want to see either. The therapy, for better or for worse, really hasn't changed since, sort of the 70s, 80s, which is sort of sad. Not for lack of trying, but we really haven't really done much in terms of how we treat people. There's generally two phases, what's called induction, that's the first chemotherapy someone gets. And that's generally a drug with cytarabine or Ara-C, and then combined with another drug called daunorubicin or a similar drug. After that, we actually give then we give further treatment, because if you just stop there, 95+% of people who have AML are going to relapse. It's almost a guarantee. You have to give additional therapy. And this is one of the areas of debate. Well, how much? What type? And so I didn't put much in there other than we usually use different, other drugs, sometimes the Ara-C or cytarabine, sometimes stem cell transplant. But this is where there's a lot of work is being done, but also it's part of the real frustration that our biggest problem is we just can't really keep the leukemia in remission to cure it. Two exceptions. One is what's called the AML core binding factor. It's a category that's pretty well defined, and interestingly, standard chemotherapy actually has a reasonably good cure rate for that subtype. The most interesting subtype is what's called acute promyelocytic leukemia, or APL. Relatively uncommon in the U.S. This is what it looks like under the microscope. What you can't see is that these leukemia cells are sort of chock full of little blue dots, what we call granules, which cause this very typical bleeding tendency in this leukemia. And in the olden days, when I'm talking about in the 70s and 80s, if you didn't bleed to death, you had a pretty good chance of cure with standard chemotherapy. I mean, it was that bad. This is one of the sort of crowning achievements to the date of leukemia care, and that this is a leukemia that has a 90+% cure rate with no chemotherapy. And we use a vitamin A derivative and arsenic, good old-fashioned arsenic, known for a couple thousand years. That combination provides these incredible cure rates and a much lower risk of people having literally fatal bleeding. So it's actually one of the amazing sort of discoveries of a relatively modern age. Well, this is haven't had the greatest news, and we keep trying to, how can we do better? Well, part of it is understanding the enemy. We're getting better at sort of delineating better, ones that we can cure with higher frequency, ones that we have a terrible track record, and people in the middle. So we're obviously trying to do better with all the groups. But the first thing to do is try to figure out who are we treating? What are we treating? We have old-fashioned tests. These are what are called the chromosomes, the cytogenetics. We have these newfangled molecular tests that are being done, and they are helping us figure out to sort of put people into different categories in terms of what therapies to select. But one thing that, because this is a disease mostly of older individuals, we've also sort of rediscovered some really just old-fashioned things. Well, who's in the house? What do you do day to day? Who's going to help take care of you? This is very intensive therapy. This is not something that someone who lives alone can deal with. And we're getting a better handle on, again, to whom should we offer different types of therapy. I'm going to sort of jump by that. Generally, 60 years old and AML is sort of considered it's a mark that we use. If you're under 60, higher remission rates, which translate to higher cure rates, but also if there's a relapse, there's more options, principally stem cell transplants. If you're over 60, we worry. For some reason that we don't fully understand, individuals who are over age 60 with AML, it's a worse acting leukemia. All things being equal, it just is harder to treat. And so what we're, again, getting a little bit better at is trying to, what we call stratify people. Who really should we talk about very intensive therapy? I mean, you're committing weeks in the hospital versus someone where we up front, we know we have a very low risk, very low likelihood of cure. And we're just trying to keep the leukemia under control for the longest period of time, but with acceptable side effects. And this is a little diagram that is where, some of it's sort of obvious, but we're slowly but surely trying to get a better handle on how should we talk to people and about what should we talk to people. The problems, we can't get people into remission. We can't keep our patients in remission. If they relapse, the outlook is really poor. And then, as mentioned, older individuals, again, 60 is sort of an arbitrary age, but for some reason it really is there's some magic dividing line there. It still really makes it very difficult to keep leukemia in remission. So some recent studies, these were presented just at the American Society of Hematology in San Francisco this past December. We're trying to get, it's a little snapshot of things we try to do. So this looks at basically for individuals whose leukemia is relapsed, looking at sort of a fairly standard treatment we give to try to get the leukemia in remission. And this drug, Vosaroxin, is interesting because it's actually a antibiotic related distantly to Cipro. And so it's sort of an interesting concept that, hey, maybe there's something here. And the long and the short of it is that it did show some benefit, but it's not the home run we had hoped. Another therapy was looking at sorafenib, or Nexavar, which is a drug that's available. It's been available for some years for kidney cancer and liver cancer. It's a pill. And there's been some hints it may be helpful in leukemia. There's hints that it may sort of interfere with some of the growth pathways that drive leukemia. But it's actually a pretty hard drug to tolerate. And you throw this on top of pretty hard chemotherapy, you're looking at a pretty tough road to go down. So this was really a study looking at younger individuals under 60. Again, some promise. It looks okay. But it was definitely a much more toxic drug. It added a lot more side effects. So its future is uncertain. One treatment for our older individuals with acute myelogenous leukemia who really aren't considered candidates for intensive therapy, and it's a treatment that especially in the U.S. that we've used for a long time, called azacitidine or Vidasa. It's a drug that's approved for another blood condition, but it was actually developed back in the 60s as a leukemia drug, and then shelved, and then sort of rediscovered in the late 80s, early 90s. And the British actually did sort of a definitive trial where here's a group of individuals clearly do not want, or their doctors don't think they can tolerate therapy. So half got Vidasa, azacitidine, half got sort of whatever their doctors wanted to prescribe. And what ended up was that the Vidasa, which is a drug that can be given as an injection under the skin, actually did better. So again, not great, but it actually provides at least some hope that we have a reasonably well-tolerated therapy that actually can help keep leukemia under control. The next leukemia, acute lymphoblastic leukemia, or ALL, is really, we think of it, most people hear about it, it's a childhood disease. This is the most common leukemia of childhood, where our pediatric colleagues have had phenomenal success over the years. This is actually the disease that sort of had hematology oncology joined at the hip, so to speak. Because back in the olden days, we're talking in the 40s, there was no chemotherapy. Then, so by accident, chemotherapy is discovered, and then all of a sudden, the hematologist who spent most of the time looking at blood under the microscope all of a sudden could treat leukemia. So this is ALL. Actually, it's still looks like the AML. And there's a reason for that, is even under the most expert eyes, you're wrong 30% of the time trying to figure out what it is just looking at it. But ALL treatment sort of follows the general pattern. You give a very intense induction therapy, first treatment, but you need to give additional treatment. And in ALL, this additional treatment can go on for a year. It's called maintenance therapy. We've gotten better, but in adults, we're not as good as our pediatric colleagues. So some of the most exciting things have not been more chemotherapy or new chemotherapy, but it's the realization we can get the immune system to help us out. So this is a drug that was just approved called blinatumomab. And it's an interesting compound, and what it does is that it's given intravenously, actually continuously intravenously, but it brings the person's immune system to the leukemia. And that's this little thingy here. It brings your good, your T cells, your immune system, in close proximity to the leukemia cell to allow the leukemia cell to die. It lets your immune system do the heavy lifting. Very interesting, very exciting. Not a home run, but we're getting a little smarter. Probably the most exciting treatment is what's called CAR T cells. This has been in the news over the past couple years. It's sort of been popping up. This is yet another type of immune therapy. This is a trickier one. And one of the reasons it's moving so slowly, it's incredibly laborious to produce. The idea is you harvest or pull out the person's own immune cells. These cells are infected with a virus that actually, engineers the immune system to develop basically a better targeting mechanism to leukemia cells. And so what are called the CAR-T019, the target is called CD19, which is present on a lot of leukemias, ALL and CLL, as you may have read in the paper. And basically brings, and then these are given back to the person. They're grown in the laboratory and given back to the person. But the idea is, let's let the immune system do the work. And because children whose ALLs relapsed, it's very horrible, but they're very hard to treat. And so that's one of the reasons these initial studies were actually done in children. And it is a phenomenally effective therapy. When people who get one treatment, 90% plus at least have some response, about 85% go into a remission. And these are children who have relapsed. And what's been interesting, and one of the reasons that trials have been moving along so steadily but slowly is, well, how long does it last? How long do these things hang around? We don't know. But actually now we have a better idea. The University of Pennsylvania that's pioneered this are finding that in individuals a year out, 2 years out, they can still see these leukemia cells, these immune system cells floating around in the blood. So it's very exciting. So great for children. What about adults? The adult studies are ongoing, but as I mentioned, one of the most interesting studies is in the chronic lymphocytic leukemia arm, because they can basically use this thing, this same device or construct to treat CLL. Now that's and it's like, gee, if it's so laborious, how are we going to do this? Well, the good news, industry has figured this out already. They've actually have experience in doing large-scale immune therapy production. So, in the near future, Stanford will probably be the site. I am told by Stanford that they'll be the site for this therapy on the West Coast. But that's a long ways away. It's a very time-consuming process, but incredibly exciting because we're starting to move away from just more of the same chemotherapy. CML, chronic myelogenous leukemia, fairly uncommon, but this is really considered, again, another one of the major triumphs. What's made it easy is that it has a very unique genetic abnormality called the Philadelphia chromosome. This is where material from one chromosome, oops, there it is, chromosome 9 and chromosome 22 swap. This produces what's called the BCR-ABL or BCR-ABL oncogene, and this is the driver. It's a very unique finding found only in CML and drives the formation of CML. So naturally, well, can we target it? The answer is yes. We now have this many drugs approved for CML, which is great. They all work well. The problem is, well, which one do you use? It sort of depends which doctor do you see. So one thing you can do is because they all work well, is take advantage of, well, what about side effects? They all have side effects. Well, some dangerous side effects, but are there side effects you want to try to avoid? So the most commonly used drug, or previously the first drug, imatinib or Gleevec, this is sort of what revolutionized treatment. Annoying side effects, not dangerous, but really quite annoying side effects, especially if you're taking it lifelong. But you can look at these different side effects. If someone has, say, heart disease, for instance, you probably want to stay away from ponatinib and nilotinib. These are not the friendliest to the heart. If someone has lung disease, you might want to stay away from dasatinib or Sprycel. If you have bad diarrhea, ulcerative colitis, you might want to stay away from bosutinib. And so we can use at least the side effects to help us guide us, well, what's a good therapy? Because they all work very well. Gleevec, if anybody is taking Gleevec, as you may know, comes off of patent shortly. And the experts in CML are very concerned about that, as are actually everybody. It's, well, when insurance companies basically force everybody to go in Gleevec, which will be cheaper for them. Not that it's a bad drug, but there are strongly held opinions that one drug may be better than the other. And so these doctors from Australia tried to really, hopefully put people at ease. They said, well, why don't we start with Gleevec? Widely used, we have a long track record with it, not a bad drug. We can now monitor CML very well. How are people doing? And if they're not getting a good response, let's switch them to one of the newer drugs. But if you're having a good response, let's just keep you on Gleevec. And what this study really showed is that this looks like a pretty good, very safe, but maybe a good way to, figure out how to, to select drugs. Another concept in CML, because these drugs work well, is lifelong therapy is sort of hard to take, especially if there's annoying side effects. And there have been some early studies suggesting that if someone has a phenomenally good response where you cannot detect the leukemia, can you stop the treatment? And it looks like the answer is yes. About roughly a third of people may stay in remission. But even for the people who relapse, you put them back on their standard therapy, and the leukemia goes back, and you get it back under control. So this was yet another study looking at, can we stop therapy? And what was interesting about this study was two things. The longer someone had been on a good therapy, a person who'd been on good therapy, CML, the higher the likelihood they were to stay in remission. But also, what's called an MR4 it's a designation for what's called a deep response. How far underground can we drive the leukemia? So the longer someone was in a in a remission where you can't detect the leukemia, the better the likelihood they were to stay in remission. So this is actually helpful as well if someone's saying, I'm really having miserable side effects. Can I stop my therapy? I've read about this. And so it's not considered standard of care, but at least we're getting a better idea of maybe to whom we can say, hey, this is a good time to maybe stop therapy. Non-Hodgkin's lymphoma, I like this pie chart. There's now over 60 different subtypes. So I'm not going to cover 60 subtypes. But I will cover sort of three of the subtypes where there's a lot of controversy and a lot of hope. So diffuse large B-cell lymphoma is the most common subtype. This is what it looks like. This is what it looks like to the pathologist, I should say. And there's a lot of issues that have come up. As a common theme, lots of subtypes. Well, does it make a difference? Do we have the best chemotherapy recipe? Are there better ones? Do we use or not use radiation? How about new drugs that Dr. Karamlou had mentioned? What about PET scans? We love PET scans. Everybody loves PET scans. Insurance companies don't like PET scans. Are they helpful? But what about the people who relapse? How do we best treat them? So at the moment, there's a lot of subtypes in this one subtype. And there's a huge amount of argument. How do you best delineate them? Who's better at it? Does it make a difference? And the debates rage on, but we're slowly but surely coming to, hopefully, to some sort of conclusions. We do agree that, subtypes do make a difference in terms of identifying better acting and worse acting types of this lymphoma, but we still don't know if changing our chemotherapy recipe makes a difference. The most common recipe is what's called R-CHOP, Rituxan, Cytoxan, Adriamycin. Where'd you get the H? Well, the old name for our Adriamycin is hydroxydonaurubis, and that's where the H comes from. Vincristine, Oncovin, and prednisone. Most commonly used recipe in the entire world. It's not an easy one, but it can be given in one day. It's, we know how to give it. It's been given for decades. We like it. Interestingly, the French came up with a more intensive recipe that is better. Head-to-head, it's better, but we don't use it in the U.S. because it's much more toxic, but also one of the drugs that's used is not available in the U.S. And then finally, our academic colleagues at the universities love this particular recipe, what's called R-EPOCH. This was developed at the National Institutes of Health. It works just fine. The problem is it's given, drugs run continuously for 4 days. So it's really a burdensome type of treatment. Those of us who, and most people who get therapy say, it's not really better. Do I really have to do that? And so there's actually a head-to-head comparison of this recipe versus the R-CHOP we're waiting for. We honestly don't know. It's more opinion than fact, so we will wait. Radiation therapy. We still think about radiation therapy in this disease. It was the first actual anti-lymphoma therapy, since basically the beginning of the 20th century when X-rays were discovered. It works, but how much we use radiation therapy much less than we used to. We're getting a little bit better. We're hoping CT PET scans will help us. This is what a CT PET scan looks like. So this is the CT scan. This is gray blob over here. This is in the neck. This is what a PET scan, just a pure PET scan, looks like. This is a nuclear medicine test. So this is black blob there. What's called a CT PET fusion scan is when the computer puts them together. It didn't come out very well. I apologize. You see this very nice, you can see where the lymphoma is sort of sitting in this big lymph gland in the neck. That's not so obvious here. But what we're hoping is that using a PET scan at the start of treatment and at the end of treatment, if the PET scan is still abnormal, rather than more chemotherapy, maybe radiation therapy can take care of it. CT PET scans under intense debate. Our professional societies are really trying to discourage us, as are insurance companies, because the reasoning, other than money, is that it hasn't been proven that it actually helps care. So if your doctors are telling we're having trouble with getting a CT PET scan, it's not because we don't necessarily think it might be helpful, but we're running into difficulties getting them covered. Oops. One of the ways that PET scan, we're hoping, as I mentioned, PET scans might be helpful, is really helping us decide, well, which individuals might need radiation therapy and might not. Because this was a study that actually tried to answer that question, what's called limited, so not extensive, so lymphoma that in a relatively small area. Everybody got chemotherapy. Everybody got a couple PET scans. And then if your PET scan was positive, suggesting still active lymphoma, you got radiation therapy. Or if the PET scan was negative, we could do more chemotherapy or nothing. The end result of the studies really suggests that the PET scans are helpful in selecting people who could use radiation therapy to really boost their cure rates. So we're hoping this might reverse the tide of PET scan denials, but we will see. New drugs. This is a list of drugs that actually Dr. Karamlou had discussed for CLL, and they look like they're good. They're being added to standard chemotherapy. They're actually being used for people who may not be considered good candidates for chemotherapy. Gazyva, obinutuzumab, that Dr. Karamlou mentioned, is looking at, could this be a better Rituxan? So a lot of things are in play. It's mostly sort of, can we make a little bit of a difference here or there? Follicular lymphoma, the second most common non-Hodgkin's lymphoma. You can probably see this better than I can, but it gets its name because of these sort of pale things right there. Those are what are called pseudofollicles in a lymph node. It's really considered what's called an indolent or slow-moving lymphoma, but people still need treatment at some point. Most people will need treatment at some point. But how do we select those people? Who really needs treatment? When do we start treatment? Do we start right away? Can we wait a while? How long do we treat? Short, long, forever? And then how do we monitor people who have this disease? Because it's a disease where it'll shrink down, go away, but it relapses. If you ask the doctors across the U.S., how do they treat people? It's sort of random, just like it depends on who your doctor, who your doctor is. You can see this is just a selection of all sorts of different treatments. One issue about how long to treat is we all agree if someone needs treatment, treatment works pretty well for most people, but can we keep the lymphoma in remission? So one of the big areas has been what's called maintenance therapy with Rituxan. Not chemotherapy, no hair loss, no nausea, no vomiting, no effects, no effects on the blood counts, but it's an IV, and it does have some potential long-term side effects. And so there's been debate. For the most part, we've accepted, why don't you give some extra Rituxan? Seems like a good idea. In the US, we had a large study that looked at, does it make a difference? The long and the short of it is, maintenance Rituxan is not necessary. It's not unreasonable, but it's not necessary because if you treat someone when the lymphoma relapses, they do just as well. So that actually put a lot of people's mind at ease who didn't want to do treatment for sort of a couple years versus that there's no harm to that. An exciting non-chemotherapy treatment, lenalidomide or Revlimid that we use for myeloma, combined with Rituxan, really looks quite good in this disease. And although the Rituxan is an IV, the Revlimid or lenalidomide is a pill. A whole lot more tolerable than a lot of the IV therapies we give. Idelalisib or Zidelig, again used for chronic lymphocytic leukemia, is now approved in follicular lymphoma. Works pretty well, has annoying side effects, but it looks like a very good drug. Oops. Ibrutinib or Imbruvica, also used in CLL, is being studied, not yet approved, but it looks quite promising. Mantle cell lymphoma, an uncommon subtype of non-Hodgkin's lymphoma, but one that it moves quickly, responds well, at least initially, but then sort of grows back, and our treatments, especially when it relapses, are not very good. There's a couple issues. Does everybody need treatment? If someone's very ill, the answer is easy, yes. What if it's sort of found by accident? There's actually a lot of debate. Many doctors say, no, this is a bad lymphoma, treat right away. Very aggressive therapy. Other docs will say, it was found by accident, you look fine, we'll do the scans, including a bone marrow biopsy, scans, but doesn't look like it's moving very fast, and it's now acceptable to say, well, we can just hold off and see what it does. You can get an idea what's called the pace of disease. That's now considered acceptable. Didn't used to be, but it's okay to do that. Treatment, if someone's not eligible for a stem cell transplant, we take our standard R-CHOP that I'd mentioned before, which doesn't work very well, but now we add in another drug that we use in multiple myeloma called Velcade. That's where the VR comes from. It seems to do a little bit better than CHOP. Not a home run, but better, and doesn't add a whole lot more side effects. The Norwegians looked at young individuals and said, well, what can we do? Can we do better than what we've been doing? So they pioneered some very intensive therapies. But what they basically found that if you treat someone very intensely, including a stem cell transplant, with a very specific, not specific, but using a specific drug, cytarabine, that I mentioned for AML, your long-term cure rates, it's really hard to see, actually are not, they're not great, but they're better than 0. So we're, again, sort of doing a little bit better with our standard treatments, but we have room to do a lot better. Oops. And finally, for mantle cell lymphoma, we've been sort of lucky. It's a rare disease, but it's easy to study. And so we've been found that Velcade, the drug that is now approved, both for initial treatment, but also as for relapse. Revlimid or lenalidomide, approved for multiple myeloma, is also approved for relapse. And then just most recently, ibrutinib or Imbruvica is also approved for this disease. So even if this lymphoma relapses, we have some, not terribly toxic, but some reasonable options. I'll just put one word in for Waldenstrom's macroglobulinemia, a favorite among us doctors. Not common. It's pretty rare. And it suffers because of its rarity that there's no specific treatments for it. We sort of, in the old days, we treated it like multiple myeloma, even though we sort of realized it's not really acting like multiple myeloma. Now we think of it as a sort of a slow-moving non-Hodgkin's lymphoma. For the first time, literally just a couple of weeks ago, it got its own drug, and ibrutinib, Imbruvica, got approved for it, which is actually pretty nice because this is a disease that very often I feel bad treating people because I'm not sure, I know I'm going to make them feel worse. And it's nice to have an option where I'm not going to make them feel worse with standard chemotherapy. Finally, Hodgkin's disease. This was one of the first lymphomas discovered, and actually this is where radiation was discovered to be a curative treatment even before chemotherapy. This is many, many years ago. Can't see it very well, but this is a typical what's called a Reed-Sternberg cell. This is the hallmark of Hodgkin's disease. It's called an owl eyes. It came out a little dark, but there's two very dark dots right there. And then within the Hodgkin's disease is all this mishmash of all this other stuff, which is not the lymphoma. It's just normal immune system cells. And I'll come back to that at the end. Hodgkin's disease has a reputation. It's very curable. It is. And the best issue, when our issues are really, well, can we do better? Can we cut down side effects? And how do we monitor and what do we do for the unfortunate few that relapse? In the US, primarily our recipe is what's called ABVD. Works very well, very easy to give. The Germans pioneered a much more intense treatment called dose-escalated Biacop, much harder, more early and late side effects, and the debate rages, is one better than the other? It sort of depends which doctor you talk to. As with all lymphomas, is what's called early, late-stage disease. For early-stage disease, you can generally for the most part, you can use limited chemotherapy, sometimes get away from radiation, sometimes you want to use radiation. And this is just a schematic of which is a very reasonable sort of way we think about how do we make these decisions. Just as on a side, look up here, there's younger women, what's that all about? Well, for a young woman, if we have to give radiation therapy to the chest, we boost her risk of breast cancer quite a bit. So for young women, if we're thinking about radiation, we shouldn't be. As with all lymphomas, PET scans are really helpful. We're still trying to figure out, are they helpful in guiding our therapy? Shorter therapy, yes radiation, no radiation. A lot of us use this information already, but to be truthful, we don't have it's not definitive. For the few people who relapse, we typically use, a stem cell transplant, which works okay. A relatively new treatment called brentuximab vedotin, or Adcetris, is an interesting therapy. And it's called an immunoconjugate, is that you have an antibody. So this is an engineered antibody from the immune system. And the company has attached this chemotherapy drug, this thing here, to the antibody. We just use the antibody to drag the chemotherapy drug to the lymphoma cell and kill it off. Not a new concept, but this company, Seattle Genetics, has done it very well. It still doesn't cure most people. This is where the immune system comes in. That first slide I showed you said, well, there's Hodgkin's disease, all those immune system cells. One thing that's been realized is that, and it ties together a lot of things we notice about Hodgkin's disease, is that what are all those immune system cells doing there? And people who have Hodgkin's disease, their immune systems are never normal. Even after they're cured, their immune systems are not normal for the rest of their lives. What's that? Why is that? What we realize that these Hodgkin cells one way they shield themselves from the immune system is they basically produce what's called PD-L1 or PD-L2. This is something that basically kills off the immune system that's coming to attack them. Well, coincidentally, we've just had 2 drugs approved for melanoma that basically deal with this. But it also explains, I mentioned people who have Hodgkin's disease have these immune system issues. They're prone to shingles, they're prone to infections. What happens, something about the Hodgkin's disease, even if it's cured, it causes what's called immune exhaustion. It's basically continually shutting down the immune system, and the immune system can't recover. And so actually it's very interesting. It explains that explains all these things we've noticed for decades. So now we're finished. Thank you for your patience.